Okay. Well, thank you for having me here today. I'm really excited to talk to you all about some of the services we're offering here through our Riley Outpatient Clinic. Just a little bit about me. I am a clinical child psychologist by training, so everything I've ever learned has been about children and families. And I have been licensed here in the state of Indiana for a couple years now, and I graduated in 2020. So I have been working with kids now for the better part of a decade, and I am currently the director of our suicide prevention services that we're offering here through our Riley Child Outpatient Clinic. Essentially, that's what INCARES is, in addition to some other services that we offer. Overall, my specialty is working with kiddos and treating life-threatening behavioral health disorders. So I really started my career working with kiddos who were aggressive with their families and in the community, continued to specialize in substance use. And these days, I focus most of my attention on kiddos who want to die by suicide or feel as though they want to die by suicide. I will say that my bias is that we treat suicide on an outpatient basis. And even though care has kind of traditionally leaned toward a more inpatient focus for these kiddos, I'm hoping that today we can talk a little bit about how we can augment our services on the outpatient level to kind of help keep kids in the community where we think that they'll be happiest, certainly, and hopefully the safest. So just to set the stage a little bit, suicide is the second leading cause of death of youth within the United States. And that is similarly true among Hoosiers. I did not spell that correctly. So the Indiana suicide rate is actually much higher than the national suicide rate. And this is something that I would say has been observed across a few. I also conduct research. This has also been observed in some of our clinical trials where it seems that our Indiana kiddos are flagging for suicide more frequently than we're seeing in maybe other states across the country. And what we also know is that suicide is even even more prevalent within rural communities. We think about a variety of things that might contribute to that. I mean, I grew up in rural Kansas, of all places, right? I remember what it was like growing up on the farm. You didn't have a lot of access to services, you had a lot of access to lethal means. And we certainly can even notice that there are, cultural norms within rural communities, especially farming communities, where there can be some stigma around mental health issues that may get in the way of completing your work. So we can even see here we're looking at the suicide death rate within Indiana, and we can see that it's highest in more rural counties. And so certainly an issue for our rural folks across the state. Part of what I want to sort of orient us to, in addition to talking about our own services and what we can offer through Riley, is that we really all have a role, myself and any provider that interacts with kids or adults, to kind of combat suicide and engage in suicide prevention. I'm going to talk a little bit about what those things look like, in part because I want to make sure that it's clear sort of where our services fit in within the continuum of suicide prevention options. And we'll offer some support there at the end to kind of help you in this endeavor. I think the biggest way that everyone, both healthcare providers and community members, can really help to combat suicide and engage in suicide prevention is really focusing on the role of stigma and doing our best to destigmatize these things for our patients. So patients are often afraid of what response they're going to get when they're disclosing suicidal thoughts and behaviors. My clinic focuses exclusively on kiddos who have identified suicidal crises. It's very common that the kids I see have attempted suicide at one point in their life. And knowing that we're going to treatment to talk about suicide and address these issues, I still have kids who have a hard time telling me about their suicidal thoughts and behaviors. And in part, this is because they are kind of afraid of what they're going to get when they enter these systems. I mean, I think one conversation that stands out to me, and I'll talk about some of the principles of this, but just going over some of the information I have around why suicide happens and some of the psychoeducation. I remember talking to a kid who, even though I was pointing out that these thoughts can be logical and normal within our experience, she was talking about how, like, if you went to the ED and everybody just looked at you and were saying you were crazy and that maybe you needed to go into the inpatient unit and why do you want to kill yourself, you would feel awful too. And she was totally right. And so I think from our perspective, what we want to do is really be thoughtful about alleviating stigma and recognizing that suicidal thoughts are often a logical solution to suffering, even if it isn't something that we view as the best or preferred solution. When we as providers have a calm, open demeanor that leans toward problem solving, that is suicide prevention. That is the sort of stance that's going to help children and adults disclose these thoughts and feelings more often that can then help us get them to care. Part of reducing the stigma can be changing our language. I just have some examples on here. Completed, committed, and successful. We want to avoid any language that would suggest that there was like a goal that could be met or not met using suicide. And in fact, what we know is that families who have survived suicide, they prefer the term died by suicide for their loved ones. And I would also point out that committed suicide was actually a term that was popularized by the fact that suicide was illegal in certain states. So they committed suicide, kind of like they committed a crime. So we really want to shift our language toward more objective descriptions of behavior. So died by suicide or just suicide. Failed attempt, non-fatal suicide. We really want to just talk about suicide attempts or suicidal self-directed violence, suicidal self-harm. Parasuicide used to be a term that was used more frequently. Now we prefer non-suicidal self-injury or non-suicidal self-directed violence for self-harm that maybe didn't include the intent to die by suicide. And then we also want to avoid any language that would suggest that people are trying to manipulate us by uh, threatening or stating suicidal thoughts. So again, we just want to use as objective descriptions of behavior as possible. Okay, so this is the slide that I will always talk about in every suicide presentation, and I imagine that certain providers who may have listened to me multiple times are really sick of me hearing about it. But from my perspective, understanding this is sort of the key to destigmatizing suicide and helping us understand what we can really do for people to help them have a life worth living that isn't so painful. And the first thing that's really important to understand is that suicidal ideation is rarely, if ever, about wanting to actually die. What we really see is that what happens is sort of this imbalance, this internal imbalance between the pain that I'm feeling, right? Think high distress, really hopeless about the situation, their ability to handle it, right? We're really, really upset. And we have no idea. We have low coping ability. We don't have the ability to deal with those distressed feelings or those distressing situations. And in that way, when our brain sort of sees the situation where we're intensely miserable and in so much pain, and we have no idea how to make it stop, our brain is going to come up with, you should die. You should die by suicide. In fact, we know that 92% of people will have these thoughts of, I should die, I want to die. So, really, when we see suicidal ideation, what we're seeing is maladaptive problem solving, right? We're seeing our brain sort of jump to the most permanent solution to that problem. And what we really see along these lines as well is that that is really about suicidal ideation. When we think about attempts to die or actual death by suicide, the thing that increases risk for that is access to lethal means. So the reason I point this out is because every effort that we make as providers is really to address this imbalance, right? I will talk about what some of those strategies may look like as we go through. Like some of you might be familiar with safety planning. Safety planning is all about increasing the coping ability of a patient within a moment of risk so that we are not relying on suicidal ideation to get us through that moment. We also, I imagine a lot of providers are also very familiar with access to lethal means counseling, making sure families have things locked up and kids do not have access to things that could cause them to die. This is what we see as reducing actual attempts, right? So, for instance, I have a kiddo who was attempting to attempt suicide probably once a week, but she wasn't able to do so because everything was locked, right? The locking of the stuff does not make the suicidal thoughts go away, but it does help keep our kiddos much safer. Okay, so I do want to talk a little bit about the overall steps of triage, right? Because we may have identified someone with this suicidal risk, this imbalance between coping and distress, and we then have to figure out like how to get them to care, right? And so these are our general steps of triage, and I imagine most folks are familiar with what this looks like to a certain extent. So we're always going to start with screening, then we'll move into a more thorough assessment, and then we'll want to make a clinical decision. So for screening, you may use the PHQ-9. I will say some more things about specific screeners. We also have other tools available to us, like the Ask Suicide questionnaire. We also may move into an assessment, right? So what the thing is that are going to be told to us in the screen is that we've had these thoughts, we've maybe had a plan, we've maybe attempted, right? Like these are very basic questions. We then would need to go into a more thorough suicide assessment to figure out what do we need to do with this kid right now. One of the interesting things about suicide risk, and I imagine that this is something that is well understood from a clinical perspective, but isn't always translated easily into our documentation, is that anybody's suicide risk fluctuates, right? Just because I see a kid on Monday and I look at them and I go, yeah, you're fairly low risk. I'm not, you're not telling me of a plan. I'm not seeing anything upcoming that I think would increase your risk. So I might look at someone on Monday and say you're at low risk for suicide. Who knows what that person is going to look like on Wednesday after they've had a test at school, or their partner broke up with them, or they got into a fight with their parents, or heck, they were just having a really bad day, right? So we know that these things fluctuate. So our goal with screening is to capture the kids who are experiencing any amount of suicidal ideation. And when we're looking for with assessment, is really what do we need to do with this kid right now to address that risk? Some of the things that we might do include hospitalization. Some of that might include follow-up outpatient care. We'll talk a little bit about what those things mean. And then the last part is you're going to kind of triage about that, right? So we know some level of risk has occurred, and then we need to set up like the appropriate referral and follow-up steps. Okay, so in terms of risk screening, overall, universal screening is recommended at this point. We don't always know who those kiddos are who are in high distress. I would say that most of the kids I see don't fit like this standard depression diagnosis with suicidality. A lot of my kids have a much more complicated presentation and sometimes have gone under the radar for years. I think one of the most stark examples I have is that we had a referral for a kiddo who was expressed a little bit of suicidal ideation, and then upon further assessment, she had had ongoing suicidal ideation for about 4 years. And so it's important that we're kind of checking in on everybody to get as many kiddos as we can, especially knowing the potential high risk for these kids. Um, we do want to make sure that we're doing it continuously. So just because someone came in to their appointment a year ago, they didn't have any suicidal ideation, does not mean that that's not going to be the case at our next appointment. That's even true for me when I'm seeing patients like every week. I'm reassessing this stuff. So just because we have a history of a suicidal screening does not actually mean that we don't need to do it again. In fact, we should probably be doing this every time we have patients coming into our offices. And then we would also recommend that this screening and assessment be suicide specific. So even though most people who experience suicidal ideation have a co-occurring mental health diagnosis, that's still only 90%. So what that means is that there is a chunk of folks who are going to be experiencing suicidal ideation without an additional mental health diagnosis. And so relying on something that isn't suicide specific to help indicate when you should be screening for suicide is not as efficient as we would want it to be, especially kind of when we're trying to identify something as high risk. So here's examples of some of the tools you can use. The Ask Suicide questionnaire, Ask Suicide screening questions, seems to be the one with the most research within pediatric populations, especially within the emergency department. What you'll notice is that they ask a lot of very specific questions about suicide. So, wishing you were dead, feeling as though other people would be better off without you, specific thoughts of killing yourself, right? These are several ways that we assess for suicidal thoughts. One thing I might even point out is that from a clinical perspective, it is pretty relevant for me as a clinician to know whether my kiddos are experiencing thoughts of wanting to kill themselves or wishing they were better off dead. There are slightly different like clinical interventions I might use for those things. That's also different level of risk for me to know about. And when we look at this, you can see that we're asking about these thoughts a few different ways, a few different times. And when we're using other screeners, what we're often seeing is that there's one question about like, do you wish to die? Or do you want to kill yourself? And that just isn't as efficient at getting kind of the breadth of the potential behaviors we have. One thing that I've certainly noticed working with kids is that they do seem to get very stuck on what was a suicide attempt versus self-harm. So I will find that a lot of my kids get very adamant about it was not a suicide. It was not, I did not mean to die. By the way, I think as providers, it's very important for us to respect that when people tell us, even though we might be concerned about the lethality of that, letting them kind of have the validity of that experience and what they were trying to do at that time is helpful to them and helps us just kind of keep that rapport while focusing on a high risk behavior. The ASQ does better than standard depression screening and is relatively short to administer. So I would recommend the ASQ, but there are other options that get at suicide screening. The Columbia is another one that's frequently used. I do want to say a few limitations of the PHQ-9. You might kind of imagine what some of those might be based on what I just said. It only uses one item to assess for suicide risk, which really may be missing some valuable information. We know from research that these suicide-specific screeners are better at identifying risk for suicide than the PHQ-9. It also limits reporting to just 2 weeks, and especially with suicidal behavior, we would want to see a longer course. What I would say is that anything is better than nothing. So if what your health system can support is the PHQ-9, which has a suicide item on it, then that is great. That is better than doing something that does not have the suicide item on it. And I would really recommend considering a suicide-specific option to sort of make sure we're capturing as many kids as we can. The next step would be suicide risk assessment. Now, whether this is something that happens within your, purview is its own thing, right? So whether or not you're doing a follow-up assessment is going to be based on kind of your time, what you're qualified to do. But a risk assessment basically involves getting more information about those suicidal thoughts and behaviors so that we can effectively triage the next step. There's lots of things on here. I think something that is super easy is the safety. I see this a lot within pediatric settings. It really is just a note card that you can put on your badge that sort of goes through what the additional questions you might want to ask are. The Columbia, it has both a screening version that like you would hand to somebody to have them fill out. They also have like a follow-up interview form that we can be using when we're doing clinical assessment. And then the brief suicide safety assessment is a part of the ASQ and that kind of suite of products. And so I would recommend any of these if suicide risk assessment is something that you plan to be doing within your setting. And, the more that you know about suicide and what the different risk categories might be, the more comfortable you're going to be asking these questions and making referrals. So even if like you don't have time or ability to engage in like a full suicide risk assessment, I would recommend kind of looking into what these things are to get kind of just a more nuanced perspective on what we might be looking for when it comes to suicide risk. And I'll talk a little bit more about what we kind of see in terms of risk categorizations. But when we think about, okay, so we've done this screening, we've done this assessment, what the heck am I supposed to do with that, right? What we often see as a barrier to doing any suicide screening is people going like, and what am I supposed to do now that I know that, right? No one wants to have a kid go home and die. Also, no one wants to be the person to find out that this is going on and then have no idea how to treat it. And so when we think about what might be possible decisions or options from an outpatient perspective for someone who's endorsed some level of suicidal ideation, we might expect active monitoring. So we might expect a period of time where we're just really keeping an eye on what's going on with this kiddo. We might also see like a brief intervention. Brief interventions would largely include safety planning and sort of helping kids figure out how to manage their high risk moments. You might want to make sure that they're being referred to a provider within a given time frame based on their level of risk. And then potentially you may be looking to seek out crisis or emergency services. So, right, you can kind of see a varying level of risk and how we might want to respond. So, putting it together, this is sort of what we view as sort of the general categories of risk. We have low, moderate, and severe. I'll put a little plug out there to say that, these risk categories are not, I think, particularly helpful in the sense that, these things fluctuate. And so just because someone is low risk or moderate risk one day does not mean that's going to be the case the next day. And when somebody's sitting in front of us, these might be sort of how we categorize based on low, moderate, or severe risk. So thinking low risk, we might have thoughts of death, just limited to those thoughts, thinking about dying, thinking about wanting to kill themselves, probably haven't identified a plan, probably don't have any intent to do that. We might even see kids with really identifiable protective factors, right? So really involved family, maybe they have some additional therapy resources. We might also see a few risk factors, right? So a family who is able to engage in really well done means restriction. We would also suspect that their mood and psychiatric symptoms, those could be mild to severe, but we would expect them to be able to be independently be able to remain safe. So no access to lethal means and just this ability to sort of maintain a safe environment. For moderate risk, we may be looking at suicidal ideation. Again, we would kind of anticipate limited intent to die or a limited non-specific plan. Could be kind of vague. I get a lot of vague plans like, I would take pills or I would hang myself. But I find that it's pretty rare that I get a more intense plan. We might be seeing past suicidal behavior. In this case, I may or may not kind of evaluate where I would add in non-suicidal self-injury or self-harm without suicidal intent. It's something that I would be clocking, especially if it was frequent and severe. That is something that I would consider sort of raising their risk for suicide, even if by accident. Um, they may have access to lethal means, but they could be amenable to that lethal means restriction. And then, oops, for severe risk, we would see suicidal ideation with a plan and intent to die. Um, and we would want to sort of look ahead, right? There have certainly been times where I've looked ahead and sort of said that with the upcoming stressors we have, we don't have the coping ability to deal with this. So a good example I have of this is when I was working in the court in Rhode Island. We had a kid come in. He had brought a gun to school, and he had been released home with an electronic monitor, kind of based on the facts of the case. They felt that he could be safely released into the community. And within that, he mentioned wanting to die within the context of his hearing. And so I conducted the suicide risk assessment. And with that, he was talking about wanting to die. He vaguely had plans. Um, and he talked about how much he really did not like his mom. And being around his mom really increased his suicide risk. Now, if you're paying attention, right, he just got put on an ankle monitor. So he now no longer has the ability to not be around mom basically all the time. So what we're seeing in that capacity is that his suicide risk fluctuates with the more time he spends with mom. He's getting ready to be with mom 24/7 on an electronic monitor, which is equally stressful in its own right. For that kiddo, because that situation was just so clearly going to change and so quickly, we did recommend inpatient hospitalization at that point. So that's sort of what we mean when we're looking at limited coping ability, where it's like reasonably like unsafe to send someone home. Um, an inability to maintain safety. So if someone is not able or willing to use a safety plan or do safety planning with you, if they have impaired judgment or they do not have a family member who would be able to engage in supervision or do the means restriction, that is very high risk. They may have had like preparatory behavior. I don't see that a ton. And it definitely comes up and is very concerning when we do see it. Notes, giving things away, starting to hoard materials, practicing or researching where they might hurt themselves or what they might do. We take that very seriously. And then, of course, the access to lethal means is one of our bigger concerns. So when we're doing these assessments, we want to talk to as many people as possible. We want to really be thoughtful about sort of this person and this system, meaning like their family's ability to keep them safe and sort of balance that with their level of risk. I know it's as clear as mud, right? These decisions can be really hard, but this is sort of a general sense of where we might go. I wanted to just show some examples of what triage decisions might look like at different levels of risk, in part so that I can point out where our services would fit in really nicely. If you were in a primary care setting and you were seeing someone with low risk, you might want to consider a consultation with behavioral health if that's something that you have access to. We might want to make sure that we're referring them to treatment for any primary presenting problems, identifying social support, and addressing any of those safety issues. At the minimum, we're going to want a safety plan. We're going to want to make sure that we have a minimum bare level plan that will help a kiddo increase their coping ability in moments of distress while alleviating or eliminating lethal means. Um, for kiddos who are in like moderate risk, again, we might be expecting a more in-depth safety plan. I might expect more like dedicated counseling. We would refer to behavioral health to complete an evaluation within a relatively short time frame, right? Remember, these are our kids who have past suicidal behavior, some access to means, and maybe some plans and attempts. So we really do want to get them to care within 72 hours if we can. And at the very least, we might want to coordinate with any existing behavioral health providers. If they're within the severe or acute risk, this is when you're going to want to transfer them to emergency services, observing the patient and maintaining safety within the environment. What I often see, based on our experience, is that a lot of people shoot right to severe or acute risk without maybe looking at options to help that person maintain their ability to live in the community. So we often see that people maybe didn't engage in like a follow-up plan or didn't get a safety plan. That's pretty common for us. Okay. If you are in, let's say, just a standard outpatient clinic, I say specialty here more to focus on children and adolescents. If you're an outpatient provider, you might just, for a low risk kid, you might continue to just monitor that risk, see if there's any potential increases in ideation, intent, or plan. We also might want to conduct and review a safety plan as needed for those kiddos. At moderate risk, again, we will definitely want a safety plan at this point. And we also want to be thoughtful about their willingness and ability to use that plan. If they are not willing to use that plan, that increases their risk. And that might kind of be moving them into this severe risk category. We want to have a commitment from them to reach out to an emergency services if something comes up. We want to refer to suicide specific treatments if available. And that is actually exactly where our services sort of sit, is a suicide specific treatment. And then we'd want to consult with caregivers and trusted adults to make sure that everybody's on the same page with the safety plan and means are being sufficiently restricted. And for our most severe risk, we would want to send to emergency services. And within that, make sure we're limiting access to means and maintaining observations. I'll tell you from my perspective, this is very, very rare that I will see a kid in my office that is exhibiting severe risk. Most of my kiddos, and granted, I get like an hour, right, to work with them and make sure we're in a good spot to go home. Most of my kids will fall into this moderate risk. I'm not seeing many kids who are in the low risk range because that's not who our services are designed for. And this moderate risk, I really do want to encourage folks to be thoughtful about it for a few reasons. Um, Outpatient, we do have suicide specific services available. Although it is extremely unlikely that people will have access to this in their communities. I'm really excited to be talking to you all about our services because they are virtual. So hopefully they can become an option for kiddos throughout the state. That's certainly my goal. And this isn't like a standard practice within most outpatient settings. Like it's pretty weird that we have these suicide specific treatment options. In many cases, especially if you're in an area where families are really preferring in-person services, they don't want something suicide specific, or for whatever reason that won't work, a referral to an outpatient provider is the appropriate next step. So I guess in some ways I want to kind of encourage people, it's not always rocket science, right? If we can get people to suicide specific services, we want to do that. And if they're not available, send them to an outpatient standard behavioral health provider, and that will help. That is like an appropriate referral decision at this point. So in some ways, I might even suggest, you know, almost setting up a process for our suicidal kiddos that's similar to what you might see for your standard behavioral health. Of course, accounting for potential imminency or need to get in sooner based on their level of risk. One thing I'll point out, I am a supervisor and team lead for our dialectical behavior therapy services that we also offer through Riley. It is, really a great intervention. It's the only well-established intervention for youth suicide risk. To date, we do have promising research evidence in other areas, but DBT is really the only one that has like proven itself already. That said, it is completely inaccessible for many of our families. The fact that we have this at Riley or starting this at Riley is relatively new. And our teams tend to be relatively small with small caseloads, simply due to just sort of the needs of the families that we're serving. So all that's to say, if you can get someone to a a dialectical behavior therapy program, that's awesome. There are certainly, we're not the only one in the state doing that stuff, so would highly recommend looking to that in your community. And again, don't let the need for like specialty services stop you from just sending a general outpatient referral. Um, Other things to point out is inpatient hospitalization, as I like to put it, is really not a zero-sum game. We know that inpatient hospitalization can increase risk for suicidal thoughts and behavior following discharge. In fact, the first 3 months after discharge is some of the most high risk time for our patients. And so, when we're making decisions to hospitalize, we are asking ourselves, is the risk that this person is exhibiting in this moment more risk and more concerning than what might happen as a result of inpatient hospitalization? We might not know that, right? As a provider, these are the clinical decisions that we're sort of stuck with using our best judgment on. And I think we want to do our best to limit inpatient hospitalization only for the kids that we feel like really need it. And the way that I might define some of those things would be an inability to safety plan, just not willing to commit to trying other things to cope with these difficult feelings, and or insufficient caregiver support. If I don't have a family who's willing to engage in means restriction for a kiddo who has pretty severe risk or moderate to severe risk, I'm going to be very seriously considering hospitalization. It might also be that you're not in a position to really make that call, right? It could be that you're in a position to send someone to emergency services and let the people there make that call. And I also think that is totally fine for you. You just need to know sort of where you're positioned within your system. And, just make sure you're doing what you want to do in terms of follow up for your kiddos. Um, this is a plug for safety planning. I'm not going to go in too much detail for this, especially for our low to moderate risk kids. Safety planning is really important. I would highly recommend any healthcare professional be able and willing to safety plan with their patients, and I am including physicians. In part because it's somewhat easy, and the main reason being that it is a frontline intervention for suicide risk. We often talk about it as the only intervention, and I would actually argue that safety plans are really used to mitigate risk rather than treat suicide. And they're also designed to help keep people on an outpatient level. Like we're basically saying your risk is sufficiently mitigated by doing this plan that we can keep you in outpatient. Safety plans need to include about 4 things. One thing I will say is that if you are just handing someone a piece of paper, telling them to do means restriction and giving them like a list of coping skills, that is not consistent with what we understand to be high quality safety planning. And the reason we do this is because we want our safety plans to be highly personalized, meaning we want to make sure that those are skills that kiddos and families are able and willing to implement. So any really well done or thoroughly done safety plan will include at least these 4 things. Identifying triggers for suicidal thoughts and behaviors. So when is a high risk time? Is it when you're at school? Is it when you start to get tingles in your fingers, right? We kind of want to, in essence, we want to help kids, we're adults, orient to when is it that you're going to want to use this plan? Is it when you're getting ready to take a test? Is it in the evening because you normally kind of feel suicidal after you go to bed? So helping people think through when to use it. We also want to give them coping strategies to use both individually and with support. The way this looks in our clinic is that we ask kiddos, or we work with kiddos, to identify 5 coping strategies that they would be willing to use or try before they attempted suicide or did something more serious. And so that can look like a lot of different things. I do it a lot of different ways. And basically, I will go ahead and put a plug out there that you do not have to be a therapist to have coping skills. We all have coping skills. The fact that you're here and have had difficult experiences in your life and you're still standing, that means you also have coping skills. And so you don't need a fancy therapy book with them all listed out to be able to help kids know how to deal with things, right? So things that all include in safety plans sometimes like would be things like watching TV or video games for a specified amount of time. In part because I use those things as an adult to regulate. Other things that I might include would be things like deep breathing, other sorts of distraction techniques or mindfulness techniques. But really, like the things you use can be the things that they use. One thing that stands out to me is that my grandma used to always tell us that when you're having a hard time, you want to count. And so, for instance, like what my aunt did at her funeral, my grandma's funeral, was to count all of the candles that were in the church. And that, that's like sort of this beautiful thing, right? Where it's like a grandma or mom teaching, someone younger than them how to cope with something. And then also being, the annoying psychologist I am, I'm like, oh, well, that's a mindfulness activity, actually. Right. So these things that we do all the time for coping, like they usually fit into bins that therapists can name, but they don't need to be named like a therapist would name them in order for them to be helpful. So I just want to make sure that like people feel empowered that like there's lots of ways to learn coping and you have many of those resources and kids tend to have more resources than they think they do. We do want to include who to contact in emergencies. We ideally would have a parent or an adult on that as well. I always ask for 911 and 988 numbers to be included and called as needed. And then we're going to limit access to lethal means with parents. Um, so thinking critically about hospitalization, I won't spend too much time on this because we already talked about it a little bit. Whether inpatient stays are fully just the worst thing. I mean, we know that there's going to be more nuance to the answer than that, right? We do know that that can indicate higher risk following discharge. It's higher for adults than adolescents in this case. Especially with involuntary hospitalization, there's like risk for harm, loss of autonomy. It can be very, I think for some kids they've viewed it as traumatic. Um, it can cause acute stress. And it can really get in the middle of like living, right? So, especially if we're having trouble at school or something, we're already behind in school and now we're an inpatient for a week and now we're farther behind in school, those kinds of things. It's costly. And then I think the really big thing that I see a lot with my kids, knowing I have a biased sample, is that they are reluctant to seek future care or disclose suicidal ideation in the future. I mean, that said, to keep in mind, like a lot of my kids have been inpatient and they still disclose this stuff to me. We just want to be thoughtful about how we're going about it. Um, Overall, just some general recommendations. I would recommend using a suicide specific screener, developing a protocol that sort of incorporates psychological support, kind of depending upon the results of that screener. And then just making sure that you have adequate time to assess. So, now I want to position our services within all of that. We are in CARES. What we do is actually a suicide specific treatment. I think I mentioned earlier that that's really weird. And I guess we like being the weirdos here in Indiana. So CAMS stands for the Collaborative Assessment and Management of Suicidality. It is an evidence-based suicide-specific framework that's been used a ton with adults, and we're beginning to do good work evaluating CAMS in adolescents. And initial trials are telling us that this is a promising intervention for kids, and I would say our therapeutic experience is that it's been a really helpful mode for a lot of our kiddos who we've had. I've really loved doing this work. Our goal is to treat suicide risk on the outpatient level because we don't want kids to be hospitalized and we want to increase the continuity of that care, right? So between what we're doing, outpatient, and other options. We're really hoping people work toward managing those thoughts and feelings on their own and turning away from suicidal coping. And we do that by expressing a lot of empathy around why someone may be feeling suicidal, talking very honestly about it. I talk with my kids about suicide every time from the beginning of our session to the end. And frankly, there have been times where um, I've challenged kids who've told me they're not suicidal because I'm like, I don't know, that just seems like a lot to change in 2 weeks, right? So we're having very honest conversations with that. And then we're working very closely together to make sure that we're moving in a direction that helps kids feel better and have more of a life that they're interested in being a part of. Just some general concepts that you might hear. We use something called the suicide status form to assess a patient's risk, do treatment planning, as well as tracking their stability over time and our clinical outcomes. What we're really working with patients to do within the context of treatment is identify suicidal drivers. So, it's really the top two problems that are compelling them to consider suicide. And, I think historically we've looked at those things as being like, oh, it's their depression diagnosis or something of that nature. And I would actually say what we do is much more specific and clear. So, a good example I have is that I currently have a patient who has very severe OCD that's very much not checked. She repeats things like lights and closing doors until it feels right. And that's taking up hours of her time every day. And, you know, I think a traditional approach might say, oh, well, if we treat OCD, then that's going to make the suicide risk go away. And there's something to that, right? But one of the things I think about for all of our kiddos is so a lot of people may have OCD, not all of them feel like dying by suicide. What is it about her experience of OCD that makes it intolerable, that makes it a problem that we don't know how to solve? And, part of my talking with her is that she's not currently in treatment for OCD. So she's feeling very hopeless about her ability to actually change these things. So, from my perspective, what I'm going to be doing is giving her psychoeducation around like the possibilities of OCD treatment, as well as connecting her with an outpatient provider. This could look different, right? Like this depends a lot on the people that we see, but we try to go beyond just the diagnoses and just the distress to really nail down like what are the things that are propelling you towards suicide. And then we do a stabilization plan. I talked about it we call it a safety plan. I also call it a coping plan. But basically those strategies people can do to reduce their risk. What patients can kind of expect from us is that suicide risk is assessed and tracked during each session. We monitor treatment progress. And we often ask that families plan for about 3 months of treatment, although I often find that families or adolescents discharge somewhat faster than that, on average, about 5 sessions. And we also would say that family participation is extremely important, especially during our initial visit when we're doing assessment, as well as making sure that means are restricted within the home. Okay, so in terms of who is appropriate, we accept referrals for kids 10 to 18. We won't go younger than that. The reason being, the work that we're doing does require a certain amount of gosh, I feel like I'm getting ready to say this like such a psychologist, like cognitive sophistication, to be able to like actually engage in some of the conversations we need to. Younger than age 10, we would recommend an outpatient referral with safety planning. Um, in general, we need people to be experiencing active suicidal ideation, meaning if you have a patient who has past suicidal ideation, let's say 3 months ago or even 2 weeks ago, this is really not the right treatment for them. I've tried to do it. I've tried to, work with people who have a history of it, and it just really isn't the best fit. Because we are so suicide specific. If they're not experiencing suicide every week, then we kind of don't have anything to talk about. So in general, we would recommend a report of suicidal ideation about once a week in order to be referred to our services. We need them, of course, to be able to engage in the safety planning process as well as means restriction. If that's something that families aren't willing to do, they're also not a good fit for our services. Who is not appropriate? Again, people with inactive suicidal ideation or something that's happened in the past. If people are in active crisis, we are not in a position to do any emergency assessments. We would encourage you to refer to emergency services. And you can also refer to us in addition, sort of knowing that that's going on, but we would not be the emergency provider. And then any developmental disabilities or other behavioral concerns that would limit that person's ability to actually engage in treatment with us. When in doubt, you can always submit a referral. I will show you how to do that here in a minute. And then someone on our team will reach out to coordinate. Okay, some relevant clinic policies. We do expect families to maintain weekly participation. We can be kind of flexible on that. And there's a little bit of, we're managing suicide risk, and that's really serious, and that needs to be a priority. Again, we are not a replacement for crisis services. We work as hard as we can to get people scheduled as fast as possible. In fact, we're building out our team and hoping to get some more therapists to kind of help meet demands. But we're hoping to get patients scheduled within about a week or two to kind of keep things moving in positive direction. And finally, we are not necessarily long-term providers. So our kiddos are discharged after they meet the resolution criteria. The resolution criteria are 3 weeks with minimal suicidal ideation and no suicidal behavior, as well as reports that they're able to manage those things well. So after 3 weeks, where we've sort of determined that risk is low, we will discharge these patients from our CAMS services. It is possible that one of our clinicians would have availability within their general schedule to keep a patient on past CAMS discharge, but that's like left up to the provider, the patients, and sort of frankly, timing is how a lot of that works. So that's just something to keep in mind. We are able to work alongside other providers because we are so suicide specific. That's our only focus. What we do does not tend to overlap with what other providers are doing with one of our kiddos. So if somebody is already in treatment, that does not mean they cannot be referred to our services. Okay. So this is kind of our general slide with all the information and sort of the kind of brief version of what I just went through. I would highly recommend like either bookmarking our referral link or the QR or using the QR code. That will take you to our referral portal. I do try to triage those referrals or assign them within about 72 hours. And I would love to make sure that we're reaching more folks in rural Indiana. So I hope that you will be reaching out. That is all I have. And so I think we have a little bit of time for questions.
Yes, thank you so much. What a ton of extremely helpful information, especially for some of the rural providers that don't necessarily get as much support or backup. One question that we did have was, your requirement at your clinics for the weekly meetings with the families. Is there any wiggle room on that, or are there resources available if transportation or internet or anything like that is an issue?
Yeah, we do. We work with families. We like to set the expectation that it's weekly, really for the main point being like we can't go like plan on multiple weeks between sessions just because like we are managing suicide risk. So our providers have to have some contact. But yeah, we work with families to make sure it's convenient to their schedule. And so that really wouldn't be a problem.